We shall start now. Good afternoon, everyone. Welcome to weekly webinar organized by College of Physicians Malaysia. We are now in the 4th week of our nephrology month, and topic for today is Art of Prescribing Diuretics. Our speaker for today is Dr. Hashwina Sukesh, a nephrologist from Hospital Selayang, and our chairperson is Associate Prof. Dr. Ruslinda Mustafar, consultant nephrologist from Hospital Chancellor Tuanku Mukris, and she also a Deputy Dean of Industry and Community Affairs Faculty of Medicine, UKM. A little bit about Prof. Ruslinda. She completed her undergrad from UKM in the year 2002 and her Masters in Internal Medicine in the year 2011 from University Kebangsaan, Malaysia. She then completed her nephrology subspecialty training both in UKM and Guy's and St. Thomas Hospital, London, UK in the year 2015. She was also appointed as Assistant Dean in Clinical Service for Faculty of Medicine, UKM from July 2023 till July 2024. From July 2024 till this year, she was appointed as Deputy Dean of Industry and Community Affairs Faculty of Medicine, UKM. She is actively involved in teaching students both from undergrad and postgraduate. She is also actively involved in publication of journals both in local and internationally. Without further ado, let's welcome Prof. Ruslinda.
All right. Thank you very much, Dr. Priscilla, for the very lengthy and complete introduction. I think as a chairperson for today's webinar, I think the most important highlight of the today's definitely Dr. Hashwina. So as we move forward, allow me to introduce Dr. Hashwina. Yeah, Dr. Hashwina is a nephrologist at the Selayang Hospital with extensive, obviously, experience in internal medicine and nephrology. She first completed her MD at the UNIMAST back in 2011, and then she received her MRCP UK in 2017. And she has served many hospitals as an internal medicine physician and also as nephrology fellow. And then Dr. Hashwina has completed her fellowship program in nephrology. Of course, Dr. Hashwina also have many contributions, includes organizing updates, examination in MRCP, and many others. And her professional achievement in internal medicine, I think could be highlighted because she received 2 Excellent Service Awards from Selangor and Johor Department back in 2017 and 2019. So it's an excellent person, all right? And she also did many research project and publication also. And of course, she also contributed to many clinical trials. So what's going to happen today, as shown in this webinar, Dr. Hashwina going to enlighten us. Very important topic because she started with the arts of prescribing diuretic. Easy to prescribe, but what would be the art of prescribing? So without further ado, I would like to invite Dr. Hashwina to continue with her lecture for today. Over to you, Hashwina.
Thank you, Prof. Ruslinda, for the kind introduction. Also, thank you to the College of Physicians for this platform. So I was given 45 minutes to talk about diuretics. Let's hope it's not too dry. This is an illustration of a woman with what was known as the dropsy. Okay, she has bilateral lower limb pedal edema, she's got ascites, she's got gaunt facies. All of us physicians, whether we are general physicians, cardiologists, hepatologists, nephrologists, we would prescribe furosemide when we see somebody like this. We don't even think twice to endorse it. But have you ever wondered how it came to be? Now, diuretics have been around since the medieval times, evidenced by many ancient texts, such as this Ebers Papyrus, which you can find at the University of Leipzig Library. It is one of the earliest surviving medical texts written in Egypt. Subsequently, 2,000 years after that, very unfortunately, we went from medicine to rather gory mechanical ways to treat dropsy. And it was based on purgatives, bleeding, sweating, and other means to make the body lose fluid, such as using this Southeast tube. If you see the metal piece here, they would stick this into edematous legs and let the fluid leak out. And when you remove this, it continues to leak out and sometimes it gets infected. And it was actually used for many years. It was only in 1500s when Paracelsus described an inorganic mercury-containing compound as having some diuretic properties. But it only became popular after 1900s when Alfred Vogel was a medical student in Vienna. He discovered that a mercurial agent treating syphilis increased urine output. He, of course, gave credit to the nurse who meticulously charted each day's urine output in a flow sheet. And after publication of the observations, mercurial diuretics became widely used in the treatment of heart failure, cirrhosis, and nephrotic syndrome. It was only in the 1937 when carbonic anhydrate inhibitors was discovered, and 1960s was quite a decade. We had man landing on the moon. We also had thiazides, loop, and potassium-sparing diuretics. Modern-day diuretics are broadly divided into 5 classes based on the predominant site of diuretic action all along the nephron. So you have the acetazolamide, SGLT2 inhibitors acting on the proximal convoluted tubules. You have the furosemide, bumetanide, torsemide acting along the thick ascending limb of the loop of Henle, and you have the thiazide and thiazide-like diuretics acting on the DCT, and you have spironolactone and the non-steroidal MRAs acting on the collecting duct. Several of these drugs act at more than one site, causing overlap between classes. For instance, thiazide diuretics, they act both on the DCT and the proximal convoluted tubule, okay? So with all these different diuretics, how do we decide which to give, how much to give? So we're going to use a very simple case example to illustrate some very important points. So we have a 60-year-old female with type 2 diabetes, hypertension, CKD3B, IHD. She comes to the ED with breathlessness and bilateral lower limb edema. Blood pressure is 140/95. She's on high flow mask. Lungs have bilateral fine inspiratory crepitations up to the mid-zone. So basically your garden variety acute decompensated heart failure. Creatinine is 250 with a baseline of 160, and home medications include perindopril, bisoprolol, and furosemide of 40 milligrams once a day. So which diuretic would you give? How much would you give? And would you give it as oral or IV? The first choice is obviously loop diuretics, isn't it? The loop diuretics, after being absorbed in the stomach, it is very highly protein bound, all of the loop diuretics. And because of that, it's a big compound and it does not get filtered in the glomerulus. So it stays within the vascular space, and then it gets, it moves via the peritubular capillaries to the proximal convoluted tubule area, and it goes into the epithelial cell at the PCT via the OAT channels, which is the organic anion transporters, and it goes out into the lumen via the MRP4 channels. And then it moves, goes downhill, goes flow down to the loop of Henle, and it goes up into the thick ascending limb of loop of Henle, and it finds the NKCC channel, and it blocks it, and it prevents sodium reabsorption. So that's pretty much how most diuretic works. They all reach the luminal transport site through the tubular fluid secretion, and they all have high protein binding capacity. So the main mode of action is basically blocking sodium from being reabsorbed. The proximal convoluted tubule, you have 70% of the sodium being blocked as to be reabsorbed, but unfortunately that 70% gets reabsorbed along the way as they move down. And the loop of Henle, it blocks 25%. This DCT, if you give diuretics here, it blocks 5% and collecting another 2 to 3%. So based on this, you know that loop is definitely the most potent, okay? So in a normal situation, when there is excess delivery of sodium to the DCT, when your loop prevents the reabsorption, all that sodium goes into the DCT. And the macula densa senses it and triggers the TGF, and ultimately the GFR of the same nephron decreases so that it can help the nephron to reabsorb whatever excess sodium there is. This is what happens in a normal situation. However, it turns out that macula densa cells also contains NKCC symphotis. So when you give loop diuretics, it actually blocks the macula densa and it prevents it from the salt sensing ability in these cells actually decreases. So the TGF does not get activated and the GFR does not drop, it remains. So you get more sodium and water removed, okay? So basically loop diuretics, this is the second point, loop diuretics impairs CGF. So this is another reason why you should give loop first. Having said that, our physiology is actually rather complex, and this doesn't always happen. In fact, some studies have shown that it reduces GFR by about 20%, but it is not due to tubular injury. It is mainly due to reflex renal vasoconstriction. So now we know the theoretical reasons why we need to choose loop diuretics, but is there real-world evidence? So the evidence and in these papers, they're quite old, but they're quite valid. 1966, Tyson and a group proved that loop diuretics actually led to a larger and quicker diuresis than either acetazolamide or spironolactone alone. And when given in combination, they had an additive diuretic effect. And the other paper 10 years later, they compared thiazide diuretics and loop diuretics, and it showed that loop diuretics actually had greater diuresis and better symptomatic improvement with lower side effects. Okay. So of course, first choice, loop diuretics, most potent, less adverse effects. But which loop diuretic should you choose? I know ultimately it comes down to dollars and cents. You would want to pick the furosemide, which is like 6 cents a tablet, versus bumetanide, which is like 90 cents per tablet. But you know, you want to see the properties of each of it as well. Furosemide is about 50-60% in bioavailable after absorption. It is very variable depending on the patient situation as well. Bumetanide is a bit more stable, 80-100%, and torsemide is 68-100%. Torsemide is longer acting, so it remains in about 3 to 4 hours in the system. Furosemide, bumetanide, shorter acting, but furosemide is 100% kidney metabolized. Bumetanide has 50-50, and torsemide is more metabolized in the liver. Adverse effects, you know, everybody knows adverse effects of loop diuretics: hypotension, hypokalemia, metabolic alkalosis, hypocalcemia, hypomagnesemia. All these are very common. But you also have hyperuricemia. So because it is binding to the O channel, so competitively inhibiting it. So you have some patients getting a gouty attack when you give higher dose of loop diuretics when they're inpatient. So be careful of that. Also, it causes ototoxicity, but you have to remember this mainly happens in patients with some degree of renal impairment, and furosemide definitely higher risk because it is purely renal metabolized. Whereas if you give bumetanide or torsemide, the risk of ototoxicity in somebody with renal impairment is probably lesser. So despite being the first FDA-approved loop diuretic in 1966, I'm talking about furosemide, and it's the most frequently used, there's still limited data to support the superiority of furosemide when compared to other available loop diuretics. There are a lot of head-to-head trials comparing different kinds of loop diuretics, whether it's furosemide versus bumetanide or furosemide versus torsemide. But basically, it's quite mixed. The ones I highlighted preferred torsemide compared to furosemide, but a transform study actually says there was no difference in all-cause mortality between both of these groups. So how much would you want to start with? How much to give? This is an English physician, Wilfred Stokes, and he once said, the dosage of furosemide is largely arbitrary. It is governed by limits of known safety, experience, and recommendation. And I think half a century later, very little has really changed. So few factors that you need to consider when deciding on the dose is, does the patient have CKD or heart failure at baseline? Is the patient already on loop diuretics? And what is the threshold and therapeutic dose for this patient? So in CKD or heart failure patients, these are some of the factors that may affect the choice of the diuretics that you're going to give. You may have decreased tubular delivery and secretion of diuretics because there's same sodium load but fewer nephrons. At the same time, CKD patients have RAS activation, so there's limiting salt excretion because RAS activation will cause the salt to be reabsorbed. At the same time, you may have albuminuria, so you may have low albumin in your serum, therefore less protein for binding, and therefore the drug cannot get to the action site. And then gut edema, on the other hand, would cause the drugs to reach the threshold dose in a slower range. So diuretics, loop diuretics, a lot of times behaves in all or none fashion. You may have if you have like no edema, the dose that you require is lower for you to get a response in terms of diuresis. But if you had edema, you may require a higher dose before you get a little bit of diuresis. So that's what it means by threshold dose. And if you give IV, you would peak up faster than if you gave oral. Okay, so this graph basically would guide you whether you should give IV or oral, and whether you should give a lower dose or a higher dose. Okay. For CKD patients, it is mainly secretory effect. So you can reach the same peak therapeutic dose as a normal person, but it takes some time. Okay. But for heart failure patients, you may not reach the normal therapeutic dose as a normal person because There is arterial underfilling. It is associated with diminished nephron responsiveness to diuretics. And when there is diminished responsiveness to diuretics, you might have some proximal tubular reabsorption as well. So there's less sodium to actually be excreted, okay? So IV or oral? IV definitely faster, oral definitely slower. IV, you must remember that IV stays in the system for a shorter duration, 2 hours compared to 6 to 8 hours. So when you're dosing the patient, you have to frequently dose the patient to prevent post-diuretic sodium retention. On top of that, GI absorption influenced by edema, all this you have to take into consideration. What does the evidence say and what does the guidelines say? Evidence is contentious, but guidelines is pretty clear. The European Society of Cardiology and the AHA guidelines, they did mention that patients hospitalized with heart failure who are already baseline on a loop diuretic, they should start at least 1 to 2 times the usual daily dose of oral diuretics in divided doses, and it should be started as IV. But if they were not previously on diuretics, any form of loop diuretics, then you can start in lower dose, but you can titrate it up. The NICE guidelines just says higher. It doesn't say how much higher, but definitely higher than that of the oral dose on admission. And definitely give IV also. So this is a summary of the therapeutic dose, or the minimum required therapeutic dose in different situations. And this is from the textbook, Comprehensive Clinical Nephrology. So if you had renal impairment, severe renal impairment, you want about 200 milligrams of furosemide before you can get a therapeutic response. But if you had congestive heart failure, you may not need 200 milligrams, you just need 80 milligrams IV. We're talking about IV here, okay? So your same patient is now admitted to the ward. You've started IV furosemide, 80 milligrams BD. She has persistent crepitation, still on high flow mass, urine output only about 1 liter. So your first question is, how much more furosemide can I give? So now this is a graph summarizing most of the latest trials surrounding loop diuretics. And based on this, you can see that the response to loop diuretics is pretty much subject to a law of diminishing returns, which means doses above certain threshold do not induce much greater diuresis. So if you see here, lower dose, higher urine output. Higher dose, not so much urine output. So beyond a certain level, actually it doesn't bring about any more diuresis. That means there is a ceiling dose. Ceiling dose means beyond a certain dose, you may not get any more diuresis, but you might get toxicity. What is that ceiling dose? We don't know. It is really individualized. You have to see based on your practice. You might realize that certain patients you gave 80 milligrams and the next day you increase to 120 milligrams and the urine output did not increase further. That means that probably the 80 milligrams was probably the ceiling dose. Or it could also be that the patient has some form of diuretic resistance. We don't know. What is the maximum per day dose that you can give for furosemide? It is 600 milligrams per day based on our formulary UBAT KKM. And even the memes did say that 600 milligrams per day should be the recommended maximum dose. Okay. The next question is bolus or infusion. There are a lot of trials done looking at this, bolus versus infusion. I think the most popular one is the dose trial. And they did say that despite some differences in which the bolus dosing arm had twice as likely to require either increase in loop diuretic dose or addition of a second diuretic, which means to say that bolus may not be doing so well. But despite these differences, there was actually no difference in weight loss, fluid loss, or freedom from congestion or improvement in symptoms between the continuous or the bolus dosing. How do you assess response to diuretics? Urine output or net fluid-based algorithm of diuretic dosing can be challenging, but you generally traditionally use urine output, weight, and blood pressure. But the problems with this is multiple confounders, it can be inaccurate, and there's delay in data collection. In your general wards, you wait like 24 hours, you take urine output monitoring per shift. So, it takes some time before you are able to detect any non-responders early. But of course, if you're in the ICU and CCU, you're doing hourly urine output, then you probably can detect non-responders earlier. So what is a more objective way? That is to gauge natriuresis. You can measure the urine spot sodium 1 to 2 hours after diuretic administration. There are some predicted equations that you can use to adjust subsequent diuretic dose, but it cannot tell you whether it is because of insufficient loop diuretic delivery, not enough drugs that reach the action site, or because the sodium is being reabsorbed more. It cannot tell you that. Okay, there are some MDR study that can help to elucidate this best, but it is still, jury is still out on this. This is a push AHF trial, which randomized patient to standard of care and intensive care. So standard of care, basically you gave twice daily IV diuretics, and intensive care, you really followed the urine sodium, spot urine sodium, and if that is not enough, there's less than 70 millimoles per liter, you would up the diuretics. And it concluded that natriuresis guided diuretic therapy did improve 24-hour natriuresis and diuresis in patients with acute heart failure, without impacting the all-cause mortality or heart failure rehospitalization, which means to say that it did not really translate to heart outcomes. And you have to remember the practicalities of doing this in a busy clinical setting, in a general medical wards. It has to be considered if you're really planning to adopt this kind of a response assessment. The fourth question is, should you go with protocolized treatment or clinician-directed treatment? Okay. A normal physiologic diuretic response, if you give 40 milligrams IV furosemide to somebody who is completely normal kidney function, no heart failure, you should get about 3 to 4 liters of urine output in about 3 to 4 hours. So sometimes your patients are not normal, so you don't know what is normal. So therefore, some people prefer the protocolized stepwise diuretic dosing algorithm. Like this is an example from the CARES-HF. So if the urine output was not 3 liters per day, then they escalate it up. They go up and up at level A, B, C, and D. What they found in the post-hoc analysis comparing that, the stepped approach against the DOSE and the ROSE AHF trial, which was clinician-directed approach, they found that the protocolized approach had greater net fluid and weight loss without being associated with renal compromise. Now, that is a good thing. But if you protocolize everything in medicine, then there goes the art of prescribing diuretics, isn't it? On top of that, you have to remember your patients in most general wards, they come with acute heart failure precipitated by CAP, precipitated by some cellulitis or ACS. You have so many things going on. So you really have to individualize the approach. The fifth question, should I just stick in a catheter for sequential ultrafiltration? Forget about diuretics, just dialyze him already. So again, the CARES-HF trial, it showed that there was a trend with higher rate of all-cause hospitalization or death in the UF arm. Okay, so don't stick in the catheter first time, but if they are non-responders, then definitely consider dialyzing this patient. So the second day in the ward, the patient is still on IV furosemide 80 milligrams CDS, still on high flow mask, urine output still 1 liter per day. So why isn't the urine output increasing, and how to increase the diuresis? So now we talk about diuretic resistance. There are a few literature that says diuretic resistance can be defined by certain things like the urine sodium, so on and so forth. But generally it just means that it is a failure to increase fluid and sodium output despite escalating doses of loop diuretics to a ceiling level. Okay, so you have an acute tolerance, you have chronic tolerance. Acute tolerance usually refers to breaking phenomena. Chronic tolerance usually refers to distal tubular structural adaptation, both of which causes increased sodium reabsorption. So in the breaking phenomena, basically each time after you give the loop diuretics, the body responds because there is a dip in the serum sodium and the blood volume just after you give the loop diuretics when it is in function. So when that dip happens, the RAS is triggered once the diuretic has already worn off. So when the RAS is triggered, what happens is the sodium is absorbed. So each time you give the loop diuretics after that, there's less sodium that is being excreted because a little bit more has been absorbed just before. Okay, so that is pretty much what is the breaking phenomenon. And then you have the post-diuretic sodium retention. Okay, this usually happens acutely, but if this continues to happen, then you might have this chronic tolerance, which is due to all the distal tubular epithelial cells, which is exposed to all that sodium that is not being absorbed by the loop of Henle. So all that sodium would cause hypertrophy of the epithelial cells. When there's hypertrophy, there's upregulation of the MCC. When there's upregulation of the MCC, there is definitely more sodium that's being absorbed. So what is the solution? Acute tolerance, you have to dose correctly, dose frequently, and definitely go for dietary salt restriction. Chronic tolerance, use a correct dose, and go for sequential blockade. So besides dealing with the true cause of diuretic resistance, you have to make sure the other factors are dealt with as well. Make sure your diagnosis should be correct in the first place. Your patients might actually have something else like infection, parapneumonic effusion, malignancy. Maybe the legs are not really pitting edema, maybe it's lymphedema. So you have to get the diagnosis correct, because if you kept giving furosemide and drying these people out, you're not going to get much of a response. On top of that, if you are removing all that salt with all the diuretics that you give, and your patient continues to take more salt, some of you of the hospitals, they have salt packets coming and the patient would pour the salt on their food, then there's really no point to this treatment, isn't it? So adherence is really important. Decreased drug delivery. If you have hypoalbuminemia, your drug cannot reach the site. If you've got gut edema, it is going to take some time before the drug reaches a threshold dose. So this has to be tackled as well. Then decrease drug secretion. So if you are using the OAT channels, you don't want to be on drugs that is competitively inhibiting that OAT channels as well. And then, of course, you deal with the true diuretic resistance. Now, how do you treat diuretic resistance? First of all, maximize loop diuretic efficacy. So if you're on oral, you might want to consider changing to IV because of the bioavailability. And you might want to dose it more frequently rather than giving furosemide OD. Maybe you want to give it TDS or QID, depends. And consider switching for furosemide to bumetanide or torsemide. Of course, we don't have torsemide here. Bumetanide, I know you have to call your nephrology colleagues, but it is more bioavailable. So you could consider switching if you find that if you think there is some form of diuretic resistance. Albumin infusion trials have shown mixed results. It may be beneficial in profound hypoalbuminemia, and also definitely they use it in chronic liver disease. But yeah, mixed results in terms of trials. And then dovitamin, we actually don't do that anymore. Octreotide is for your liver cirrhosis. Sequential nephron blockade. Now, what is that? Basically, you block your loop, you block your distal. You can also block the proximal. So it's loop plus a thiazide or a thiazide-like, or you can add on a collecting duct blocker, or you can add on SGLT2 inhibitors or acetazolamide. Acetazolamide is one of the older ones in the modern diuretic group of drugs. But the ADVOR trial was recently published. Unfortunately, the ADVOR trial was designed without the SGLT2 inhibitors. So we don't know how it will work with SGLT2 inhibitors or in eGFR less than 20. SGLT2 inhibitors, I know it is for proteinuria reduction, it is for your renal protection, your cardiovascular protection, but it is also a very weak diuretic agent. It acts on your proximal tubules. It prevents sodium glucose reabsorption, right? Okay. So what is the evidence? This is a DAHF trial. It compared 3 types of diuretic regimens. So furosemide plus metolazone resulted in a higher natriuresis compared to only furosemide or furosemide plus acetazolamide. Okay, so thiazide and thiazide-like diuretics are usually the next to go-to diuretics if you want to do sequential blockade. So you have thiazides and thiazide-like because of the compound difference. Now, thiazide-likes, they can be used in eGFR less than 30, but thiazides not so much. Clothalidone in the CLIC trial showed that it is still important in hypertension, and metolazone we still use in end-stage renal failure patients, especially PD patients who still have urine output. Their adverse effects is very much similar to loop diuretics, except that they might have hypokalemia more because of the inhibition of the potassium switch. There's increased calcium reabsorption. There's definitely hyponatremia on both sides, but this is slightly more. And hyperglycemia because of the hypokalemia that mediates the inhibition of insulin release. Now, is there a preferred thiazide or thiazide-like diuretic? Is metolazone superior? A lot of literature that you read, you might find that metolazone is touted as being superior to the others, maybe because of the inhibition of both the proximal and the distal tubular function. But a lot of trials have shown that it is not. There is a direct comparison of metolazone with blenroflumethiazide. This is an RSCT. They found no superiority of metolazone. This trial, although in the beginning it showed that metolazone had higher urine output, after 72 hours, it's not any different in terms of the efficacy, the safety. So no clear evidence that any single one is superior, suggesting actually a class effect If you want to use another drug other than thiazide, or you want to add on to it, then consider using spironolactone or non-steroidal MRAs. But non-steroidal MRAs are very weak diuretic agents. So spironolactone, on the other hand, it has some evidence in the Rails trial with regards to death from any cause in patients with cardiovascular disease. The fine arts and emphasis did use the non-steroidal MRAs, but it's mainly for cardiovascular outcome, not so much of diuresis. What are the other drugs with diuretic effects? So as I mentioned earlier, the acetazolamide. So we're not sure about it in the lower GFRs, which most of our acutely ill patients have. They did not include patients with severe diuretic resistance, and it was not used together with SGLT2 inhibitors. Mannitol definitely has a lot of urine output when you use this. It has enhanced water diuresis, but it is not used for volume overload. You have the intravascular hypertonic phase. It can cause a bit of APO after giving that, but it is useful for decreasing intracranial pressure and increasing free water excretion in hyponatremia. In SGLT2 inhibitor, definitely there is some evidence, MPARC-HF, MPAR-Response, MPULSE, but the safety in acutely unwell patients, we don't know. Most of these SGLT2 inhibitors we use in patients who are pretty stable. Aquaretics like tolvaptan, they are used in like PKD. It acutely increases the serum sodium, but it does not improve the long-term morbidity and mortality. And on top of that, it induces thirst. So you don't really want your acute heart failure patients to be thirsty any more than they already are. So you decide to add metolazone, you step up to 10 milligrams PD, the patient is on fluid and salt restriction, urine output is 2 to 3 liters, you can bring down the oxygen, but the creatinine starts going up. So should you withhold the diuretics? This is a very common referrals for the nephrology team. Basically, if your serum creatinine increases because of the heart failure, it is associated with increased mortality and frequent hospital admission. But if your creatinine increases from successful diuresis, then it is associated with decreased mortality as long as decongestion is occurring. Basically, what I'm saying is the patient is drowning, you can forget about the kidneys for a while. This is a trial. It's called the worsening renal function in patients with acute heart failure undergoing aggressive diuresis is not associated with tubular injury. I think the title speaks for itself. So they looked at the baseline and 72-hour biomarkers of kidney tubular injury. They looked at the NGAL, NAG, and the KIM1, and they looked at, this is based on the A is cystatin C and B is creatinine. And basically, there is not much difference between patients with and without worsening renal function in terms of the change in tubular injury biomarkers. So the creatinine rise might not be due to tubular injury. So this last bit, I'm just going to say a little bit about patients with end-stage liver disease and nephrotic syndrome. How do we diurese these group? Patients with chronic liver disease, you want to go for mineralocorticoid receptor antagonists as a diuretic of choice because it sidesteps bile acid that free fatty acid mediated inhibition of the O channels. Why? It doesn't go through the O channels. It actually goes through the basolateral diffusion. So it directly goes through that, so it doesn't use the O channel, so that's why you prefer this. On top of that, cirrhosis patients usually are associated with hyperaldosteronism, so you want this antagonism. So there are some trials that looked at whether you should give furosemide, spironolactone, or both. Basically, if you're using a single agent, spironolactone has better response. If you're using combination therapy, you have to remember that it is faster, but most likely to have some degree of side effects and lab abnormalities that needs to be monitored. And a lot of times patients who are on dual therapy, there is a high chance that you will need to reduce the diuretic therapy for either side effects or increasing creatinine. This is because the aggressive diuresis in patients, cirrhotic patients, a lot of times they lead to AKI, because if you have a lot of ascites, your patients with chronic liver disease have liters and liters of fluid in their peritoneal cavity, but only about 0.4 liters per day of ascites can be mobilized back into your intravascular space. So when you give diuretics, you pour out more than a liter. a normal person pours out 3 to 4 liters, you may be pouring out just 1/4 of it, but still the 1 liter is still a lot more than the 0.4 that goes back into intravascular space. The 1 liter comes out from intravascular space, so you're intravascularly quite depleted. So patients with a lot of ascites, refractory ascites, you might want to consider paracentesis, tips, and liver transplant. So this is why aggressive diuretics actually result in AKI. So nephrotic syndrome, you can get diuretic resistance because there's decreased absorption from the gut. So you change your furosemide from oral to IV, or you give bumetanide because bumetanide is better bioavailability. There is also decreased delivery from the hypoalbuminemia. If you're nephrotic syndrome, your albumin in the beginning is low, so your drug cannot actually go to the site of action. So sometimes you might consider giving an albumin together with your loop diuretic to improve the drug response. And on top of that, there may be intrarenal edema. If you have edema outside, you probably have edema inside as well. So that prevents the threshold dose to go up faster. So you might require a higher ceiling dose. Mercurial diuretics have pretty much faded into memory, and for the last 60 years, not much is new. But the understanding of diuretics in clinical practice is evolving. And I think what is important is the understanding of the drug, the physiology of the human body, and a personalized approach in treating what was known as the dropsy. Thank you. That's all.
Right. Thank you so much, Dr. Hasmina. Very comprehensive lecture in the afternoon. Quite not easy, you know, very technical physiological lecture. Any question? Let me have a look. So far, no question. Really, no question. So good topic, ma. All right, maybe I can start a question because I always love questions on clinical. You mentioned about diuretic resistance, right? And with the breaking phenomena, do you think by converting the boluses to infusion would stop the breaking phenomena? Would help?
So the breaking phenomena is, yes, theoretically, it happens when your diuretic is worn off. So when you have continuous dosing, it's supposedly you continuously have that, so you don't have the breaking phenomena.
Yeah.
So I suppose you could say that, but it actually doesn't translate into outcomes in the trials. Trials do not show that it is really superior. So if it truly is stopping the breaking phenomena, then our trials would definitely show that effect as well. Theoretically, definitely it makes sense, but in real world, it's not, you know.
But no harm to try, right?
Of course, no harm to try.
When we don't have any other options. So I'm throwing this because most center, they do not have other option like Selayang. They have metolazone, they have all other diuretics that can play around. Some center, maybe in a district hospital, you only have furosemide, for example. So you have to try. That's the arts, you know. Sometimes you cannot really go by guidelines to treat your patient. You have to go individualized. Following that, another question. If we considered one diuretic is considered a resistance, do you think by switching it to another loop diuretic also would develop the same response? For example, from furosemide, let's say we have furosemide. If I have given a maximum dose of furosemide and very minimal output, would changing to the other type of loop going to be similar, or it could be different?
It could be different because the bioavailability is different. Loop diuretics, if you see the furosemide, the bioavailability is lesser than torsemide and bumetanide. So bumetanide and torsemide is more stable and more reliable dose. So that is why a lot of, I think overseas people actually like torsemide. So it is different. That is one thing, bioavailability. Second thing is the metabolism. So in the metabolism of bumetanide and torsemide actually has some degree of liver metabolism. So in terms of toxicity, when you give a higher dose of bumetanide and torsemide, you might not get the same toxicity as furosemide. The response slightly may be different.
Yeah. All right. Any question, Priscilla? So far, none, eh? Wow, so clear with the lecture. You ask question, you answer. You ask question, you answer. That's why no questions. All right. So I believe diuretic is very important drugs, be it oral as an outpatient used and also IV as inpatient. For the IV, essentially we are treating for acute decompensated heart failure, acute liver failure, and in refractory nephrotic syndrome, right? So just another practical question. If I have a patient who on IV and patient's getting better, how do you decide on conversion? Let's say on IV 80, and then you get the right dose, the right urine output that you have, and now you are discharging. How you make decision in terms of, okay, this IV, is it like macam equal 80 to 80? How do you do that?
So based on the table that I mentioned just now, the conversion is basically 40 milligrams of oral IV furosemide equals to 20. It is actually half. So you just now you said 80 milligrams of IV, is it? Okay.
Yep.
Okay, so 80 milligrams of IV will probably be the same as 40 milligrams. Sorry.
Yep.
Yeah, correct. Yeah. No, it's the other way around. So 40 milligrams of IV is equivalent to 80 milligrams of oral. So you need to double the dose when you're giving furosemide. And when you're giving bumetanide, 1 milligram of bumetanide is actually 40 milligrams of furosemide. So that is the rough thing. But you have to take into consideration the maximum per day dose. So if you're already giving 80 milligrams of IV, you don't want to give 160 milligrams of furosemide like TDS, probably giving 80 milligrams TDS, and then you don't want to convert it completely to 160 milligrams TDS. Of course, it's still within the 600 milligrams per day, but you might end up with a lot of side effects, electrolyte imbalance and whatnot. Some patients, after the acute period, they might actually require lower doses, and a lot of patients, we actually give double, so you probably want to give a thiazide or a thiazide-like on top of your furosemide, then you would give a lower dose of furosemide. I mean, maybe maintain an 80 milligrams CDS and then add on a thiazide diuretics.
All right, great. Before I throw another question to you, let's take a question from the attendants there. Anonymous, does furosemide can still be continued in patient develop worsening EGFR over the years like CKD? Okay, like for example, diabetes, hypertension, hyperlipid, CKD, started on furosemide for failure symptoms of PD edema. I think the patient had CKD with failure symptoms. So do you continue if the patient had advancing EGFR, that's stage 5, for example, or dialysis?
Yeah, definitely. I mean, you have to see whether the patient actually still requires it. If the patient is edematous, definitely got symptoms of fluid overload, you continue furosemide. Furosemide still works. Thiazide-like diuretic still works at a lower EGFR. But you might require a higher dose of furosemide because there's fewer nephrons that's functioning. There's secretory problems, so you might require double the dose of the furosemide to get a similar response. So yeah, definitely you still continue.
Yeah, I think it's very critical to understand that in end-stage patient also, Rat Hashwina, if they still have this residual urine output, you still provide them diuretic because that helps, especially in non-dialysis. So please, if I have any GPs over here, do not stop. Because what happened was sometimes when we prescribe some doctors in KK or GP, they stop it because you're already on dialysis when the urine output is still there. Sometimes patients still can have pouring about 500 to 800 cc per day of urine output.
Yeah, our PD patients, we actually give up to 600 milligrams of furosemide per day.
Yeah,
we actually go to the maximum dose, and on top of that, somehow we give metolazone.
Correct. So this is very critical because when I receive a discharge letter from hospital that end stage started on dialysis, I always realized that the furosemide given was 40 daily. That's my clear frustration. That's why this platform giving me a chance to tell everybody, kidney failure patient, they are overload, you prescribe 40 like very tiny, minute dose. If you want to give it, doesn't touch the patient at all. Maybe just circulate in the circulation, no way to go. Yeah. You have to give higher dose, don't worry. 80, I always give 80 BD, normally morning and afternoon, not at night, because I'm scared patient pouring urine at night, we don't want to disturb them and fall off from toilet whatsoever. So 80 BD, and then lots of nephrologists decide later on, but do not give 40 OD, that's tiny, minute dose, all right. So now another question, do we still practice IV furosemide for patient oliguric or in uric AKI due to sepsis or hypotensive ATN? Meaning they want the urine to come out.
I think they're talking about also, okay, this is probably what you call furosemide stress test, FST. I actually
or they are giving just to get the urine out.
It could be some, in the olden days, our senior physicians used to call it tickle the kidney.
Yes.
Yeah, you can give. It's not harmful. You can try. There's definitely, when you've got nothing else, you definitely can give. But if you've given after 4 hours, the FST, after 4 to 6 hours, if you're given, there is actually no urine output, then you probably know that there's not going to be any response.
So FST basically trying to understand whether the patient need kidney support therapy or not. So if the patient's having urine output, so probably you can delay your renal support therapy because now kidney is showing to you, telling you they are recovering. Yeah, furosemide stress test. But you think patient overload, and suitable to give diuretic, you have to give. But if patient dry, just because anuric, you don't give. Yeah, the concept of diuresis is to diuresis the patient. Okay, another question. We're going to take as many as possible. I think it's not that easy to get Dr. Hashwina here today. Very excellent lecture. So I'm requesting everybody who have a question, please throw. No question is stupid question. We try to answer as many as possible. Some practical question also will do. So does diuretic still have antihypertensive effect for end-stage kidney patients who is already anuric? The other way around.
Okay, so end-stage kidney disease patients, a lot of times your blood pressure is high because of the fluid. Your fluid is the one causes the BP high. So you want them to be euvolemic. When you're euvolemic, you actually manage to taper down a lot of their antihypertensive. So those diuretics that we mentioned just now that we still use for end-stage kidney disease patients, definitely if you bring down the fluid, the blood pressure comes down. So yeah,
So
indirectly,
if they are anuric, do you still prescribe?
Anuric, no more. Anuric, we don't we prescribe. I think the spironolactone was tried for HD patients at one point. I don't know what is the outcome of that trial, but yeah, diuretics as in anuric patients, not so much.
Yeah. So the principle is quite easy for end stage. Still have urine output, then you have to prescribe diuretic higher dose. If the patient already anuric, they're telling you, doctor, satitis 2, meaning do not prescribe. You're just adding an extra pills to the patient unnecessarily, and patient going to drink more water. All right. No other questions. Maybe I can ask your way of practicing in prescribing diuretic in your CKD patient, because it's nephrology month, right? How do you prescribe? Let's say maybe I have a CKD patients, quite straightforward. I make it straightforward, CKD stage 4, recurrent fluid overload, but never require hospitalization. How do you approach that kind of situation? You increase dose. Do you consider to add on thiazides when the eGFR less than 30?
Yeah, actually, I do consider adding thiazides. Of course, we don't have the chlorothalidone, and we are a bit restricted with metalazone in CKD patients due to the import permit and whatnot. So certain selective patients, we think they are definitely going to go into end stage soon. We may try metalazone, but the metalazone issue is basically cost. But if we had no issue with cost, definitely I will put them on metalazone. But if not, I actually do try to put some of them on HCTZ as long as they don't have any pressing electrolyte issues.
Yeah.
And
So
then
this
that other thing is spironolactone, definitely cause trispironolactone. There's no harm in that. Only danger is the hyper K.
Yep.
So these patients, when the creatinine is getting worse, and you have to monitor more frequently, like you can't like 6 monthly.
All right. So this is very an art. So we need to understand how Dr. Hashwina practice. So guidelines stating that whenever eGFR less than 30, look that thiazide diuretic won't work, right? But I still doing it because we have no other options. Sometimes you just add on 12.5 or not lower dose, 25 up to 50.
It's still a high dose, yeah.
It works, you know. But
Yeah.
of course, as prescriber, then you have to monitor the patients. You don't just let the patient go 6 months, come back to you. Yeah, of course, you have to optimize the dose of loop diuretic. And the most important fundamental, as Dr. Shuna pointed out, sodium, salt restriction, or else it doesn't work. Yeah. And on loop diuretic, if you have metalazone, your luxury center, go ahead and monitor. In advanced CKD, still nowhere to go, then you just dialyze the patient lah. If eGFR less than 15, not refractory fluid overload. All right. Next question. Oh, this is beyond diuretic. I think this is very pressing question. Non-dialytic patients CKD 4-5. Does patients ACE inhibitor need to be continued, or should you stop?
No, we don't stop. We already know this answer. We continue if there is no contraindications. Your potassium, if it goes very high, actually we're not supposed to be stopping. We're supposed to add on a potassium binder. But if you have difficulty getting your patients taking a potassium binder, then maybe you want to cut down to a lower dose that is, with an acceptable potassium rather than completely offing that. You don't stop.
Yeah,
we actually continue in end stage.
Yeah. So I mean, another thing, maybe if I were to add, do you continue RAS blockade in end stage patient?
Yes, definitely. We continue for cardio protection.
Okay, why I'm throwing this question? This is what is happening.
Yeah.
Even though patient had heart problem, I realized they would discharge the patient with prazosin. Felodipine, amlodipine without RAS blockade. Don't do that. I mean, any MOs or physicians, physicians or in training, make sure you discharge patient with appropriate drug required for that particular disease. If the patient end stage, cardiac failure, right, ischemic induced, so RAS blockade should be there. Yeah, our responsibility as nephrologists in center is to monitor the potassium. Usually no problem one. But the heart is far more important. Do not stop, do not give prazosin. Worst scenario, siap Hytrin 4 milligrams some more. And then I was just like, these are the very important webinar that College of Physicians have for us to disseminate all the potential practical knowledge that's not being written anywhere. Kan? It's a practice point. Any other question? 350? There are many. So basically people are well aware about diuretic. Okay. If you have a patient's low albumin and I only have furosemide in my center, so you start higher dose straight away or you still play around with up-titrating dose?
Higher dose straight away.
Higher dose straight away.
Higher dose straight away.
All right. So you won't try 40 first.
No. A CKD, come with heart failure, minimum I start is 80.
Right.
I never start with 40.
Yeah, that's very important. Sometimes in ED, patient with heart failure, with CKD usually, do you want to prevent them requiring NIV or intubations, right? So you need to offload them very well. So give a good dose, look at it, and then sometimes you can prevent ventilations or NIV. Yeah? So listen to Dr. Hashwina's practical point, hit hard, and then from there you monitor. Do you practice, routinely monitor urine sodium when you're prescribing?
No. Like I mentioned just now, it is definitely proven, but it is too tedious. Busy clinical work going on. You can't be just running around doing urine sodium every 1 to 2 hours after you've given the sodium, the Lasix. You don't even know when your nurse is actually given the patient the furosemide.
Right.
Yeah, it's not so practical in our setting.
All right. So great. Any other questions? So far, none. We are at 3:52 p.m. Thank you so much, Dr. Hashwina, for your excellent lecture. Very practical and very important. Dr. Hashwina not only touching about the practical point, but also the basic understanding of loop diuretic. That very important. So if we're going to see 40 milligram of furosemide in end-stage patients, I would say this person never come to Dr. Hashwina lectures today. Then we should invite them for the next program with College of Physicians. Yeah. All right. Thank you so much, Dr. Hashwina. So I give back the session to Dr. Priscilla. Over to you, Dr. Priscilla.
Okay, thank you, Dr. Hashwina, for the eye-opening talk, and also Prof. Sinda for this session. We'll see next week, next month with another new topic. Thank you.
Thank you. Bye.